Dr. Pradeep B. Channaveerappanavar. He'll be presenting on the other way round, a case of adult onset Coats disease with an unusual presentation. So please stick to your timings.
Good morning all. As the first speaker, I welcome you all to the session. Today I will be presenting on a case study that is the other way around, an unusual presentation of Coats disease. So a case where a 53-year-old female patient presented with decrease in vision in right eye since 2 weeks. Patient also had history of hypertension since 3 years and also known case of hyperthyroidism on treatment for both entities. On examination, patient had right eye decrease in vision of up to 6/9 and the rest of anterior segment of both eye was within normal limit with normal intraocular pressures. On examination of posterior segment, the right eye fundus showed us a dull foveal reflex associated with extensive subretinal exudates. So in the periphery, we noted that there are preretinal hemorrhages associated with a doubtful mass lesion. Obviously, there was no feeder vessels on deep examination. Also, associated features were like subretinal gliosis and more inferiorly there was inferior retinal detachment. Left eye fundus was within normal limit. With these findings, we did a imaging of the right eye which showed a vitreopapillary traction. Also, what we noted was there was an inferior neurosensory detachment with subretinal fluid. Hence, we did a B scan also to note down the morphology of it, and we noted a retinal detachment with thickening, but there was no any choroidal mass or elevation noted in the B scan. The initial provisional diagnosis was made as a VPTR, that is vasoproliferative tumor of retina of a right eye. Our diagnosis was tending towards this because of the age and the presentation and the typical hemorrhage associated with mass-like lesion. But to confirm the diagnosis, we went ahead with doing a fundus fluorescein angiography of the right eye. So it showed a normal FAZ with hyperfluorescence corresponding to the exudates which we see in the fundus photo. Further, in the late phase, we saw multiple light bulb like leakages with capillary non-perfusion areas corresponding to the inferior temporal quadrant, and these characteristic light bulb lesions made the diagnosis towards adult onset Coats disease, and we ruled out VPTR in this presentation. So female patient of 51 year with characteristic light bulb features, on presentation we tend to clinically diagnose a VPTR, but with deep investigation we concluded it to be adult onset Coats disease. So we went ahead with management of combination management like intravitreal steroids, focal lasers and cryotherapy. So patient presented at 1 month because of some delay. We noticed a exudative RD about to involve the fovea. Hence initially we used cryo for decreasing its size, but could not completely do it because of the poor visibility and poor location on LIO. So we went ahead with gave intravitreal triamcinolone of 4 mg per 0.1 cc. Later at post to the cryo and the injection, the vision was stable. At the same time, the exudates were scattered and triamcinolone crystals can be seen in the vitreous cavity. Further, on OCT, we noted that inferior neurosensory detachment has settled, the subretinal fluid had decreased, and also with follow-up after the SRF reduced, we did focal laser to the those characteristic telangiectatic vessels, and on 2-month follow-up, the retinal thickening had reduced with subsided exudative RD was noted. So just a brief note on this Coats disease. Usually in the pediatric age we note it, but there are further studies where even the Shields et al. Have quoted that it can range from the age of 1 month to 63 years. In 150 cases it has extensively studied, and there are isolated case reports where the diagnosis was considered else and it came to be Coats disease in an adult onset. So pathogenesis of adult onset Coats disease is similar to the pediatric, that is the degeneration of abnormal endothelial cells causing the extensive massive exudation associated with fibrous subretinal nodules. So the important feature of this which helps us to plan the treatment is that in adult onset usually it is asymptomatic and may not present at the initial presentation. So with time its slow progression benign course may involve the macula, hence we tend to treat it. But one good thing is that it has a good favorable treatment outcomes compared to the pediatric. So this is just a fundus diagram. Even the location wise, in the typical court disease of a pediatric age, the vascular abnormalities and the exudates would tend to be involving the equator to ora, whereas adult it would be more in the equatorial and juxtamacular region. So clinical course would be good response with our treatment in the adult cases, and a majority of patients attain the outcome. So these are just few slides and studies wherein they were treated with intravitreal triamcinolone, and it subsided, the SRF subsided, and it was Ozurdex which was used for the treatment. And also there are several studies wherein we can use anti-VEGF to decrease the subretinal fluid. Thank you.
Excellent management of that case. Why did you opt not to use anti-VEGF in this case?
Some restraint from the patient side, ma'am. Not even Ozurdex, we chose the IVTA because patient's economic condition wise, we had to treat him in that.
And what about laser? So once that exudative detachment settled, did you do laser to the avascular area?
Avascular area and the typical telangiectatic light bulbs we lasered, ma'am, so that
Later
the further
on.
exudation was not.
Oh. And initially laser was not possible
Yes, ma'am.
because
Initially it
of
was not
the
possible. So
exudation.
exudative RD was.
Thank you.
Thank